Hello, everyone, and welcome to Better Together Lessons Learned from Collaboration, a session in our 25th Anniversary Lessons Learned series. My name is Pau Crego, and I work at the National Abandoned Infants Assistance Resource Center, located at the University of California at Berkeley. Our mission here at AIA is to enhance the quality of social and health services delivered to children and families affected by substance use and HIV by providing quality training, information, and resources to the professionals who work directly with these families. This session will be presented by Heather Bird and Pam Ashley. Heather Bird is the Program Director of Behavioral Health at Heartland Family Service in Omaha, Nebraska. Ms. Bird is a social worker and licensed clinical therapist with a master's degree in social work and public administration from the University of Nebraska at Omaha. She is also a licensed alcohol and drug counselor. She has worked in the human service field for over 22 years and at Heartland Family Service for 11 years. Pam Ashley is a program evaluator with STEPS and holds a master's degree in educational research, measurement, and evaluation from Boston College. Ms. Ashley has research experience in service learning, child welfare, positive youth development, and substance abuse prevention. She has been involved with community coalition management, continual quality improvement, accreditation documentation, and research-based training development. Before we begin, I want to remind you that you may ask questions via the chat feature in the lower left portion of your screen. We will answer questions at the end of the webinar, but feel free to chat them in at any point. And now I'd like to turn it over to our presenters. Thank you for being here with us today.
Thank you very much. Hello, everyone. This is Heather Bird, and Pam is on the call as well. So we're excited to talk to you today about our Better Together program, and particularly talking about not only just what the program is, very briefly, but just how the idea of the program came about, to share a little bit about a lot of the collaboration efforts that went into getting the project started and continuing with it. We have been open now for about 2.5 years. So we will include information on just how we have continued with that, and how to, I guess, start a program like this. It's a, as you'll learn, it's a program that has a lot of efforts from a lot of different providers and agencies in different service arenas. So it was exciting to be able to bring it together to get started. And then lastly, also talking about some of the important staff skills. So maybe a little bit more direct information on, if when doing this, things that we have found that have been helpful to ensure our staff are aware of and keep in mind. And part of that is threading that trauma-informed care, not just in practice with the clients, but also with each other and with all of the collaborators. So, there we go. So the first few slides I'll kind of go quickly over just to explain the program. It's a family-centered housing program that involves housing, substance abuse, mental health, peer support, and parenting to provide particularly outpatient and intensive outpatient substance abuse treatment for families involved with child protective services. We are located in one particular apartment complex, and we rent as staff an apartment there that our staff are located at, and we've transformed into staff office areas, and the clients come there to do treatment. And then the clients themselves live in the same apartment complex area. They are the leaseholders of their own apartment, and so we work with a local housing authority to help get them vouchers, which I'll explain a little bit about all of that too. But it's neat. Part of the goal is to build a sober living community environment that's not at the residential level of care, but more at the outpatient behavioral health needs, but still being in close proximity to help each other and to support each other. And also to help provide services that are comprehensive and more enhanced to help them with all the different various needs that they have, particularly to meet their child welfare goals of reunifying with their kiddos. So some of the three main goals of the program is sustained recovery. via the therapeutic services, and then reunification of the families. We work closely with the child welfare department to help work together on reunifying with their kids, or sometimes families are at risk for getting their children removed, but they're able to come into the program. And part of this is helping them with the AA meetings, child care, parenting. We have a peer support person that lives on site in her own apartment. And so she is great and has been a big part of the program and helps in the evenings and weekends to provide support to the families. And then transportation. And then also services to help them become self-sufficient. So the program, they can stay as long as they need to. It's maybe clinically about a year where they receive more intense behavioral health services when they first come, and then it's decreased over time with supportive services. And then they don't even work right away while they're with us for maybe the first month. And then they start working and take over the rent on their own. And ideally, down the road, we want to help them find their own house. But they could stay in this apartment, in this living environment, as long as they need to. And then also having the behavioral health services there to ramp services back up if they're having problems or thinking of relapsing or did relapse, that we can ramp that up. So this is just another visual of the different areas that we try to help with. So how this started was a long process, and I would say in our state of Nebraska was in a situation where we had a Nebraska Court Improvement Project and the National Center on Substance Abuse and Child Welfare did a in-depth technical assistance where they worked together to review data from all of our open child welfare cases in 2009. And so from that, we got information that over half of the cases had substance abuse problems. Of those cases, children were removed from their homes 84% of the time. And Nebraska had one of the highest out-of-home placement rates for children and families that are involved in the child welfare system. In September of 2010, the national average number of children in foster care per 1,000 children was 29.1%, and Nebraska was at a staggering 89.8%. So we were really trying to look at what's going on and what can we do and how can we provide help with these families, because this project, the IDTA, also showed a high rate of parents with substance abuse issues also had mental health problems. So we also had people, so I work at Heartland Family Service, and it's a nonprofit agency in our community. And we have a history, we've been around for over 100 years, and we have a history of providing behavioral health services and a wide variety of other different types of programming that helps with housing and parenting and a lot of things. But we had our agency staff that was involved in a work group that worked with a consultant that recommended this program that was based on the data that the project found, but also was looking at other models nationally that have been implemented in various ways with various differences. And so we started by getting all of the stakeholders involved in creating an idea of working together. We know that the child welfare has its set of needs, but it is affected by behavioral health. So you really had to bring together a lot of people from each of those systems, the justice system and the court involvement, and then also how can you help housing, because that is a huge barrier for people to be successful. And so we identified the need for an agency to really drive the idea and organize it, which is what our role was. And then an understanding of the effects of both all of the system areas and how they need to work together. And so who would be that right person? And I would say in doing that, you want to answer the need of how it benefits everyone individually first, because that will help people see why this could be helpful for them. And then the next piece is explaining it for the impact on the community. So And of course, people saw the benefits of working together with these high-risk families because they were trying to get all of these needs met in a wide variety of ways, and it just doesn't always work. So they're, as I mentioned before, they just live in an area where they can have support and therapeutic services on the whole continuum, and it has the ability to be fluid, where you ramp up when you need to and ramp down depending on the needs of the clients. And it's almost like somewhat of what they would receive in residential, but a little bit, not intense staff 24 hours, although we have a peer support person, but she's not always available at any, like a residential staff would be, we have it set up where they were able to use some housing assistance and to receive the behavioral health in a Medicaid reimbursable manner for our families. So it's outpatient and intensive outpatient level of care in the behavioral health. And then they get help with job skills and budgeting. We have a case manager that helps them with the budgeting, and then they eventually can start paying for their own rent. Now, some of them have the housing vouchers, and so that affects that. And the local housing authority in Douglas County here in Omaha we use the family unification vouchers, and they give priority to families because there's always a wait list for housing vouchers. I'm sure it is in most communities, but they loved the idea of the program because their job is they simply provide the voucher and the financial monetary assistance. They were very excited to hear of all of the extra support that we would be providing their clients. So on their wait list, they have a point system, and so they give points to people who participate in this program. And so that's kind of how we have had the ability to get those vouchers for these clients. So they may have to wait a couple months before they can get them, and then the child welfare agency in our area that nonprofit that contracts for child welfare services actually pays for a couple months of housing for their families until they get the voucher. And that has worked for this project. And then these are just some of the services. I kind of mentioned some of them that the program offers. I just wanted to have a couple slides that showed a lot of our main partners. I'm by no means including everyone, but just to get an idea of the collaboration and the scope of everyone that has helped with the program. The Child Welfare Contract Agency, and they really refer our clients, and they helped with a lot of the program planning, and they continue to help with the program planning. They attend family team meetings on site, and they help move families to permanency when reunification is not possible, even though that's our goal, but sometimes we know that won't happen. And then we help our clients access food stamps, ADC, WIC, Title 20, any of those public funds benefits that they are eligible for. The Housing Authority, Omaha Public Schools, and Early Development Network help provide some screenings for children when needed. We have a visiting nurse that provides health education on site. We have some local federally qualified health centers that our clients can use. And we bring in Nebraska AIDS Project for some HIV, AIDS information and education. Goodwill Services provides our job readiness and employment. Financial Hope Collaborative is a project that does financial literacy information. We work closely with the drug courts or juvenile court systems, and it's changed over time, but we realize the importance of having staff on their staffings, on their courts. The drug courts meet. We're meeting, a couple of them have changed in some aspects, but would do some staffing with multidisciplinary folks, and so we found it helpful to be a part of that. And the juvenile judges understand our program and work closely with us. And then Region 6 is our state block grant dollars that helps provide the behavioral health care funding along with state Medicaid. And then another big partner with us is the University of Nebraska at Omaha. They have a program called STEPS that has been a big part of the evaluation project that has started from the beginning. They helped sit at the table with us to develop what we would need to evaluate this program, and that was neat to do that together. And then obviously have been working collaboratively, ongoing through this project, and which will be helpful at the end when our federal grant is over, to really look at, is this program working, so we can help decide as a group and a community if it's something that we still want to continue. So we kind of have some visuals that Pam's just going to talk about briefly about the scope of the collaboration of the project.
So this is Pam Ashley, and I am a member of the program evaluation team working with Better Together. And one of the pieces of the project that we did is put together a systems map with Better Together staff to help tell the story of the program and also the partnerships that they're involved with. So starting with this first visual off to the left, we're just setting the scene for the situation that the clients are in terms of being part of an at-risk family that's facing the challenges of a substance abuse issue and also being separated from their children. And along the bottom, you see that the normal client, would then have to navigate their way through the recovery challenges before they could be reunited with their children. And our image of the Better Together program is this boat. And you see up on the top there, as Heather explained, the agency is Heartland Family Services, and the program being Better Together. As we tried to detail a little bit more about how the program operates, we use the propeller down on the left to represent the funding that drives the program. Up on the right, we use the steering wheel to represent those values that guide the program. And then finally, we wanted to be sure and acknowledge that their decision-making process, again, as Heather said, from the beginning of the process and hopefully through to the end, will be guided by both our evaluation efforts and also the advisory council that they've assembled. We also wanted to acknowledge that certainly a challenge and an important piece is the referral sources that direct clients onto the Better Together boat. And identifying then the core services of Better Together, here is the housing support, which is made up of both that housing management firm and also the vouchers that Heather mentioned. And then the services themselves that are core to and provided by the Better Together staff are the substance abuse and mental health treatment, the child welfare support, and parenting education. So those are the core services of Better Together. And then we went up a level on the next slide where we identified those services that are either direct services, so they're either provided on-site or scheduled by Better Together, and they include the community support groups, nutrition, health, finance, and education. And then at the top level there, our community resources are identified by those to which Better Together would refer their clients and coordinate their care. And so finally, all together, the final version of the systems map basically lays out all of the Better Together components, and together they transport the clients to the other end, which is the reunification of their families, and that self-sufficiency and economic stability. And I will hand it back over to Heather.
Great. So in thinking about the beginning of the project, how we started was really a lot of collaboration in the program design, particularly with the Child Welfare Agency, that we had several meetings to develop our policies and procedures and what this would all look like, heavy on the behavioral health needs and kind of our thoughts on the different phases of the program, but we definitely wanted to make sure we did that would meet the needs of the child welfare families and followed any rules that they had, for example, of supervision of kids that are on site, how that works, how it would work if they're with other families, overnight visitors, what do we do, how independent or dependent do we need to make the program. And so we worked together in the beginning on that. I remember with the child welfare agency, a person from there actually came along with me to look at different possible locations that we were wanting to do the program at. And I also already mentioned working in the beginning with UNO, our evaluation team, so that was really helpful to have a good evaluation plan ahead of time and not coming into that later. And then a lot of different information meetings with all these different partners to explain the program. Are they interested? And sometimes multiple times to the same place with the different people, just because of maybe staff changes or different roles have changed or some staff turnover. So just to be able to be flexible with that and just to be ready for that, I guess. And then continuing to follow up and also then grant writing. We took the lead, but obviously even reviewed the grant application together, and our evaluators were able to give input on what would work for them. And just being open to ideas. I know our agency has a history of working in the community, so I feel like a lot of people that were involved have already worked in different projects in the past together, so it was an easy collaboration. It wasn't like we were at the very beginning of meeting each other and we're new, but we both kind of everyone understood some of the systems and was able to really get together to get the project and the plan going. But it does take someone to drive that, I think, so that was helpful and to gather people and to figure it out. So ongoing, it's not all about just setting it up in the beginning. It's something you want to continue to get feedback on how it is going, and the more ways you do that, the better. So we have regular advisory council meetings once a quarter with the partners. We have joint family team meetings on site where the child welfare agency and staff are there, and behavioral health staff, the person's therapist can be there, or a case manager can provide input. Open communication and feedback, and an ongoing evaluation of the process, which is a lot of what our eval team does, but also doing this with clients, with staff, with each other. And Pam will talk a little bit more about the collaborative interviews, but we do a lot of surveys and focus groups, participate in the drug courts and juvenile court systems. And then I think the last two is the commitment to the shared governance is a value that everyone is equally important, and it's silly to have some of those turf wars that you sometimes see, and sometimes it'll get to where it might feel like that, but we quickly just kind of try and look at situations as a team and address what's happened. But one of the things we said early on is from a behavioral health perspective that we would not discharge a family without working together, that the child welfare team would be a big part of that decision as well. And then also just commitment to social learning and responsibility, that everyone is a constant learning environment, and learning as a group is most powerful, and you can learn a lot in that capacity. So
as we stepped in as evaluators and were trying to get a handle on or take a look at the collaboration effort within the system, we found a model that seemed to fit well. And that was the Wilder Collaboration Factors Inventory, and it breaks collaboration success into 6 different factors, which are listed here. So starting with the environment, whether it's conducive to a collaborative effort. Membership speaks to whether the right people are at the table and whether they have the relationships to work with each other. Process and structure talks about the participation and flexibility, the defined roles within the collaboration. Communication, again, back to those informal relationships, as well as the openness and frequency of the communication between the members. The purpose of the collaboration, whether it's clear and a shared vision among the members, And then finally, the resources speaks to the both the funding, the staff, the materials, and time, and also the leadership. So as part of the collaboration research, we did two different efforts. One was a survey effort that was, again, based in the Wilder Collaboration Factors Inventory, and that was administered to the advisory board. And then the second phase, we did a series of interviews with representatives from the different collaborating organizations. And we wanted to make sure as part of that we included representatives from all different components of the systems map that we just looked at. So what we found, and this is the some results from the survey instrument, is that there were positive reviews of the collaboration, though sometimes it varied by factor and by rater. And you'll see that while the maroon bars here for overall, the partners are broken out as the dark blue, and then the Better Together staff are represented by the light blue. And the biggest difference we saw between the groups was related to the resources. And again, that made sense to us because it spoke to kind of the awareness or closeness to the funds, staff, and the time and materials required to run the program. Mm-hmm. So when we looked at the overall scores for each of these success factors, what we saw is that these are listed in order of their scores. So the higher scores are more positive. And here again at the top of the list, there's a very strong feeling that they share purpose and that their communications are solid. That they have the right people at the table in terms of the membership characteristics. And then moving down a bit, the process and structure and environment are closely rated in terms of the structure that's in place for them to work together, and then the environment within which they work. And then finally, at the bottom, the biggest challenge is certainly the having the funds and the resources in order to accomplish the program. The second phase of the collaboration research involved a series of interviews, as I said, with 10 different folks. And these are some of the themes that came up during those interviews. So the representatives from these organizations spoke to the fact that the program, the Better Together program, serves the entire family unit. And they spoke both about the housing and also the fact that it serves both males and females. And then it also provides services for all of the family members. The coordination of services for all involved spoke to helping the clients move through or navigate through the resources that they needed. Cost savings came from both the child welfare agency that we spoke with, and also the behavioral health side in terms of the funding that they would otherwise have had to provide to these clients if they were not part of the program. Creating a safe, sober, and supportive community. They referred both to, when they talked about that community, they spoke both of the staff in the program and also their peers. So they perceived the community as both of those, and spoke of the importance of trust in that community and the clients feeling safe. Increased reunification rates simply spoke to bringing the children home sooner. And then finally, the awareness of addiction, mental health, and parenting needs among all systems is, again, navigating through those waters of recovery. The challenges that were identified were around open communication. Some of the partners mentioned the fact that they would like more opportunities maybe to provide feedback and sit down and discuss the process and the interaction. They also mentioned that they would love to know more about the program so that they could be more involved. Meeting all party needs, again, that's making sure that all of the family members and all of the clients have their needs met. The housing challenges came from the apartment management side in terms of the clients and having apartments available, and then certainly from the program side that the availability of the apartments can move clients or hold clients from getting into the program. And the last two, the collaborating to finding the right client fit, and then also coordinating early discharges, speaks to making sure that the appropriate client that has the best fit with this structure of program moves into it, and then how to handle it when the fit doesn't meet up as hoped. And back to Heather.
Okay, so we only have a few more slides, and then we should have some time for some questions. I just thought it would be helpful to include information about trauma-informed care and what that has meant for us in this whole process from program design to working together with everyone, that we have some of the principles of trauma-informed care that we have worked to implement. And I won't go through all of these, but just highlight a couple. And the first one I think is important in understanding trauma and its impact, that when you're working with substance abuse clients, that really to have information about how traumatic situations and stress impacts people and the biological changes it has, to help recognize that many behaviors or responses that seem ineffective and unhealthy in the present aren't really related to being an unhealthy person. It's more about that's their adaptive responses from what's happened in the past. And so I think if everyone can remember that, then it helps make difficult situations just easier to work through. And, you know, it's helpful to keep that in mind when we're working with professionals and coworkers as well. Supporting consumer control, choice, and autonomy is something, too, that we wanted to make sure everyone is always well informed about what's going on with their case, with all of the different systems, and because the program really helps pull all of those together, keeping everyone and the client in the loop is important, and helping them make as many of those decisions as possible. And then the sharing of the power and the governance is we try to meet and staff together with the consumer, the client, so they are informed, and really the team, which includes the client, makes decisions together about what they need or what they don't need, and to help with where they're at in their program. And then just integrating care and the holistic process of healing. And then that healing happens most often in relationships, and so setting up groups as part of their treatment is important, because a lot of that movement can happen, and also working as, you know, we are together as a community is helpful to help these families. And that also knowing that recovery is possible for everyone, regardless of how vulnerable or difficult they might appear to someone or be presenting. And then lastly, a couple staff skills that we have found helpful is, again, helping people understand the trauma and working with people with trauma histories. And it's not about what's wrong with someone, it's more about what's happened. And of course, these are things that they've done to make themselves feel better and would work. So, but also implementing specific trainings for trauma in the program. Our staff have been trained in EMDR, seeking safety, dialectical behavior therapy, TREM can be a part of it. We do a lot of child and parent therapy specifically, child-parent psychotherapy, parent-child interaction therapy. We do a circle of security group. So just a lot of, I think, evidence-based practices. And also recognizing the effects of vicarious trauma. All of our staff, we talk a lot about it. A lot of our staff have self-care plans that we talk about. And then just ongoing trauma-informed training for staff and also for providers that we have volunteered to talk about trauma at a lot of the other services that our clients will interact with, because the better we all are informed, the better we can help the clients. And then I think knowing that we can model as staff how to provide, trauma awareness in our work with the clients, and that it's collaborative and empathy is important, not a controlling or parental type of approach. And that also being free to make mistakes, I feel, is important, and that's okay, and instead of going to what are you going to do about it, that it's an opportunity for growth and to learn. That if you can figure out the reasons why anyone made a mistake, whether it's the clients or the staff, then you can find a better alternative to helping them in the future. So I know we don't have much time left, so I wanted to try and speed through some things, so if there are any questions, PM or I can help.
Great, thank you so much for that. So if folks want to type in any questions, and so far we have a couple. So first, how would you recommend to someone who wants to start a model like this one, focused on collaboration, what would you say are kind of the first steps, or like the most important components?
So this program is, I would say, to get the people from the different systems at the table and talking about it. That, it's helping the families that are in the child welfare system meet those needs, and also to meet their behavioral health needs. And then how do you help them with housing and all of those other ancillary services. But for us, it was mainly the child welfare system and our Division of Behavioral Health system that really needed to say, yes, this is something we want to do. And then also how will it be funded? We had it all set up before we got our federal grant that those two entities were going to pay for the program with the behavioral health reimbursement for intensive outpatient and outpatient dollars, and then the child welfare was going to pay for a part of the case manager and peer support, kind of that parenting piece, because when the families got into our program, then those families' ongoing needs and costs decreased. So it was really, and right now we're working on our cost-benefit analysis with our evaluation team, and it's, already we're showing that it's saving the child welfare system dollars of what they would be spending on families in other ways, such as family support, visitation, or therapeutic settings for these kids, transportation, UAs. We provide drug testing in our program, and so I think showing each of those entities how, that they can save them money and just doing things differently. But having that information ready to talk to them about that, not trying to, talk through it, but just knowing that data or that facts and taking that to them and say, this is a no-brainer. So we had that ready to go. And we were also trying to work with our managed care organization to approve an enhanced IOP model so we could bill more than traditional outpatient services. And at the same time, we wrote our grant and got the federal grant, and so we started that part of it and just dropped the enhanced funding request and billing request I think it's the best way, if you can, have a pilot project start so you can then collect the data and show if it's needed and if it's helpful. So that's kind of where we're at, is then going back to those different departments and showing them our outcomes and the cost savings.
Perfect, thank you. And then one last question is, how do you integrate your program's values? For example, you talked about the trauma-informed care principles. How did you integrate that with working with these other programs or agencies who maybe didn't have exactly the same values or didn't implement them in the same way?
Sure, that's a good question. And it doesn't always work out, but we try. And I think taking the time to explain that, and I think being flexible to having whoever can help provide that information, whether it's program leaders or managers or therapeutic staff, people working with case managers, and just explaining some of the biological changes of what's happening with people. So, I mean, it's a whole information on trauma, and I'm sure a lot of you have had, training on the trauma-informed care, and in some systems don't implement it yet. I know that's the case in our community where some do it great and some still have a hard time and are back at phase 1. But just really, I guess, trying to help explain that and make decisions together and help understand we're not kicking someone out because they relapse. It's, we're going to work with them and addressing what happened and listening, I think, and hearing what is an idea that they have and just trying things. And sometimes you might even know that it's not going to work, but we can try it, and if it's not going to have a huge impact, it's okay to not work if that's the result, as long as it's not a huge impact. But and then offering free trainings, I think, is places have a hard time passing up free training. So we have worked with our child welfare agency and said, we'll come in, we'll provide some drug education on how your staff can best work with their clients with knowing about the addiction issues and topics. So we've just offered to do that. Sometimes we're taken up on our offer, sometimes not, but.
Great, thank you.
Mm-hmm.
So do you want to add anything else? We're out of questions, but if you have anything else to add, and if not, we'll just wrap it up.
I don't think so. I think just the collaboration, when I think about our advisory council and we get people together and other helpful groups that I've been on, I think it's important to get to help other places speak on what's going on with them and sharing, and that benefits them of being a part of the group and the collaboration, and then being able to then get their input on the program. So.
Great. And we did have one comment. Kim Keating says, thank you for mentioning the use of cost-benefit analysis in your evaluation. That can be very powerful.
Yes, we're excited for that next step of our phase and to work with the providers and sharing the information with them. So.
Wonderful. Well, thank you so much for speaking with us today. And thank you to everyone who attended this session. So we have the contact information for our presenters. Also, you will receive the slides after this webinar is over in the post-meeting email. And then finally, please remember that we have other lessons learned sessions today and tomorrow, and you can register for each one individually on our site. The site will pop up once you close this window. And thank you again, everyone. Have a great day.
Thank you.
Thank you.